Emergency surgery, patient's heart stopped. Chief surgeon hadn't arrived. Operating room in chaos. Young doctors arguing. Instruments scattered everywhere. A small female nurse kept her head down, no one paying attention. She quietly stepped forward, her hands trembling slightly but precisely gripping the ruptured artery. The monitor beeped back to life. The heart started beating again. The door burst open. The chief surgeon rushed in, then froze. In that tense air, the chief surgeon only whispered, "This woman isn't just a nurse." Emily Carter was 28 years old, American nurse, petite build, long brown hair tied back neatly, pale blue eyes, gentle face. Emily had recently transferred to the major hospital, often dismissed by doctors as just a new nurse. During shifts when she suggested preparing additional instruments, doctors would brush her off. "That's doctor business. You just assist." Some resident doctors called her behind her back the shadow nurse, someone who just quietly stays in the background. An emergency surgery in the night. Patient with ruptured aorta, blood flowing rapidly. Young doctors arguing, overlapping orders, instruments dropping, nobody in control. Emily stood in the corner, head down, silent. One doctor snapped, "Don't just stand there, just follow orders." Emily had been working at Metropolitan General Hospital for 3 months. The transition from military service to civilian healthcare had been more challenging than she'd anticipated. The hospital's hierarchy was rigid and unforgiving. Nurses were expected to follow orders without question, to assist without offering opinions, to remain invisible unless specifically called upon. This was difficult for someone who'd spent years making life or death decisions independently. Emily's colleagues saw her as quiet, perhaps even timid. She rarely spoke during shift briefings, never challenged attending physicians' decisions, and seemed content to handle routine tasks without complaint. Dr. Matthews, one of the senior residents, had summed up the general opinion. "Carter's competent enough, but she lacks the confidence for anything beyond basic nursing duties." But Emily's apparent passivity wasn't due to lack of confidence. It was a conscious choice to avoid drawing attention to capabilities that might raise uncomfortable questions about her background. During her first week, Emily had noticed several instances where medical procedures could have been improved through better preparation or alternative techniques, but she'd learned to keep such observations to herself. "The new nurse thinks she knows better than the doctors," she'd overheard Dr. Rodriguez say after she'd quietly suggested repositioning a patient to improve surgical access. So Emily had adapted. She performed her assigned duties flawlessly, anticipated needs without being asked, and remained professionally invisible. But her military training never fully switched off. Emily automatically conducted situational awareness assessments in every room she entered. She mentally cataloged the location of emergency equipment, noted personnel stress levels, and continuously evaluated potential complications. These habits were so ingrained that she performed them unconsciously, like breathing. Tonight's emergency surgery was a perfect example of institutional dysfunction under pressure. The patient, a 43-year-old construction worker, had arrived with massive internal bleeding from a workplace accident. The attending surgeon, Dr. Harrison, was stuck in traffic after being called from home. The resident physicians on duty were skilled but inexperienced with this level of trauma. Emily had seen the patient during intake and immediately recognized the severity of his condition. Based on his vital signs and symptom presentation, she knew they were dealing with a ruptured abdominal aorta, a condition that killed patients in minutes without immediate intervention. She'd prepared the OR according to protocol, but she'd also quietly gathered additional equipment that wasn't on the standard surgical tray. Emergency situations often required improvisation, and being prepared could mean the difference between life and death. But when she'd suggested the additional preparations to Dr. Kim, the lead resident, she'd been dismissed. "Carter, stick to what you know. We'll handle the medical decisions." So Emily had prepared the extra equipment anyway, storing it within reach but out of sight. A nurse who witnessed the events later recalled, "Emily's eyes were strange that night, not panicked, but like she was waiting for the right moment. I'll never forget that look." Now, as the situation deteriorated rapidly in front of her, Emily faced a choice that would define not just this patient's survival, but her own future at the hospital. She could follow protocol, remain silent, and watch a man die. Or she could act. The patient's heart stopped, blood pouring out, monitors screaming continuously. The lead doctor's hands were shaking, grabbing the wrong clamps. Someone else shouted, "We're going to lose the patient." Emily clenched her fists, then rushed forward. Without asking permission, she used her bare hands to precisely block the rupturing artery. Blood stopped spurting, monitors stopped alarming. The entire room fell silent. A young doctor whispered, "How did she know the exact location?" Emily calmly gave orders. "Suture now. I can't hold this much longer." The surgical team hesitated but then followed her instructions. Within minutes, bleeding was controlled. The patient's heart began beating again. At that exact moment, the chief surgeon walked in. He stood frozen, seeing Emily kneeling under the lights, hands covered in blood, but having saved the patient's life. The crisis had escalated faster than anyone anticipated. What started as a routine emergency surgery had become a life-or-death situation that exceeded the resident physician's training and experience. Dr. Kim had been attempting to locate the source of internal bleeding when the patient went into cardiac arrest. The combination of massive blood loss and surgical stress had overwhelmed the man's cardiovascular system. "Code blue, we need the crash cart," Dr. Rodriguez had shouted, but the cardiac arrest was secondary to the hemorrhaging. Until they stopped the bleeding, no amount of cardiac resuscitation would save the patient. Emily had watched the chaos unfold with growing urgency. She could see what the doctors couldn't, or what they were too stressed to recognize. The bleeding wasn't coming from the obvious surgical site. Based on the blood flow pattern and the patient's positioning, the rupture was approximately 3 centimeters anterior to where Dr. Kim was applying pressure. In Afghanistan, Emily had learned to make such assessments instantly. When medics arrived at casualty sites, they often had seconds to identify injury patterns and prioritize interventions. This patient was bleeding out from his abdominal aorta, and the resident physicians were looking in the wrong place. Emily's military training kicked in automatically. She'd performed this exact procedure dozens of times under combat conditions, not in sterile operating rooms with proper equipment, but in desert outposts while under enemy fire, with improvised tools and no backup. "Excuse me," she said quietly, moving toward the patient. "Carter, stay back," Dr. Kim commanded. "We need space to work." But Emily was no longer following civilian hospital protocol. She was operating under the medical battlefield doctrine that had kept dozens of soldiers alive. She pushed past Dr. Rodriguez and placed her hands directly on the patient's abdomen, feeling for the arterial disruption through the surgical incision. "What are you doing?" Dr. Kim demanded. "Saving his life," Emily replied, her voice completely calm. Her fingers located the tear in the aortic wall immediately. Years of battlefield experience had taught her to identify internal bleeding through tactile examination when visual assessment was impossible. She applied direct pressure to the arterial wall, using her thumb and index finger to compress the vessel against the posterior abdominal wall. The bleeding stopped immediately. The room fell silent except for the sound of monitoring equipment returning to normal ranges. Dr. Kim stared at Emily in disbelief. Where did you learn to do that?" Emily maintained pressure on the artery while speaking. "This needs to be sutured within the next few minutes. I can't maintain compression much longer." Her matter-of-fact tone galvanized the surgical team. Dr. Rodriguez began preparing sutures while Dr. Kim positioned retractors to provide better access to Emily's hand placement. "Guide me," Dr. Kim said, his earlier dismissive attitude completely gone. "Show me exactly where to place the sutures." Emily directed the repair with clinical precision, indicating the optimal suture placement angles and recommending specific techniques for managing arterial wall tension. 2 millimeter bites, interrupted pattern, start proximal and work distally to avoid compromising the repair. Her instructions were specific, technical, and delivered with the confidence of someone who'd performed similar procedures numerous times. Within 12 minutes, the arterial repair was complete. The patient's vital signs stabilized, and his cardiac rhythm returned to normal. Dr. Kim stepped back from the table, staring at Emily with a mixture of admiration and confusion. "Carter, where did you learn vascular surgery techniques?" Emily was cleaning her hands methodically, her movements calm and professional. "I've had some experience with trauma medicine." "What kind of experience?" Before Emily could answer, The OR doors burst open and Dr. Harrison, the attending surgeon, rushed into the room. He'd expected to find either a successful surgery in progress or a patient who died during the delay. Instead, he found a completed vascular repair and a stable patient. "What happened here?" Dr. Harrison demanded, looking around the room. Dr. Kim gestured toward Emily. "The nurse saved the patient, performed arterial compression, and guided the entire repair." Dr. Harrison studied Emily's face, noting her calm demeanor and the blood on her scrubs. "Nurse Carter, I'd like to speak with you after we close." Emily nodded without speaking. A resident doctor later testified, "In that moment, we followed her orders without question. It seemed like she'd done this many, many times before." As the surgical team completed the procedure, Emily quietly resumed her normal duties, cleaning instruments and preparing the OR for the next case. But everyone in that room knew they'd just witnessed something extraordinary. And Dr. Harrison was determined to find out exactly what. After the surgery, news spread quickly throughout the hospital. Nurse Emily saved the surgery instead of the doctors. An older doctor checked her file, discovering Emily had been a combat medic in the Navy, having served in Afghanistan. During one battle, Emily had saved 6 Special Forces soldiers when there were no instruments, using only her bare hands to stop arterial bleeding. After discharge, she studied nursing, wanting to continue healing, but hiding her past to live peacefully. The surgical team was stunned. The person they'd dismissed all along was someone who had saved many soldiers' lives on the battlefield. Emily didn't tell stories or brag. She only said, "I just did what I used to do before." Dr. Harrison's investigation into Emily's background had been prompted by professional curiosity rather than suspicion. What he discovered changed his entire understanding of the quiet nurse who'd been working in his hospital for 3 months. Emily's personnel file contained only basic information: nursing degree from a state university, references from previous employers, standard certifications. But there were gaps in her employment history that suggested military service. A phone call to the Veterans Administration confirmed Dr. Harrison's suspicions. Emily Carter had served as a hospital corpsman with the U.S. Navy for 6 years, including 3 deployments to Afghanistan as part of a forward surgical team attached to special operations units. Her service record, though partly classified, revealed extraordinary circumstances. She was awarded the Navy and Marine Corps Commendation Medal for Valor, the VA representative had told Dr. Harrison. Something about saving multiple lives under enemy fire. But the full story was even more remarkable. During her second deployment, Emily's forward surgical team had been providing medical support for a classified operation in Helmand Province when their position came under attack by Taliban forces. The team's surgeon had been killed in the initial assault, leaving Emily and 2 other medics to treat multiple casualties without senior medical supervision. Over the course of 6 hours, while under intermittent enemy fire, Emily had performed procedures that exceeded her official training level. She'd conducted emergency thoracotomies, repaired arterial damage, and managed complex trauma cases that would challenge experienced surgeons. 6 special operations personnel had survived injuries that should have been fatal, entirely due to Emily's improvised medical interventions. She basically performed field surgery with minimal equipment, the VA representative had explained. Saved lives that conventional wisdom said couldn't be saved. But Emily's heroism had come at a personal cost. During the same engagement, she'd been forced to make triage decisions that haunted her afterward. With limited resources and multiple casualties, she'd had to prioritize some patients over others. Not everyone had survived. Emily's post-deployment psychological evaluation had noted symptoms consistent with moral injury. The psychological damage that occurs when individuals are forced to take actions that violate their personal values, even when those actions are necessary and justified. Subject demonstrates exceptional technical competence, but expresses guilt over casualty decisions made during combat operations, the evaluation had noted. When Dr. Harrison finally confronted Emily with his findings, she was restocking supplies in the cardiac surgery unit. "Emily, could we speak privately?" They walked to Dr. Harrison's office, where he'd prepared copies of her military commendations and service records. "I know about Afghanistan," he said directly. Emily's expression didn't change, but Dr. Harrison could see resignation in her eyes. "I figured someone would eventually find out. Why didn't you tell us about your background when you applied here? Emily sat quietly for several moments before answering. Because I wanted to be just a nurse, not a war hero, not someone with a special story, just someone who takes care of patients and goes home at the end of the shift. Dr. Harrison understood. Many veterans struggled with the transition from military service to civilian careers, especially those who'd served in combat roles. Emily, the procedures you performed tonight, those weren't basic nursing interventions. No, they weren't. You saved that man's life using techniques that most surgical residents haven't mastered. Emily looked directly at Dr. Harrison. Sir, I've seen what happens when people die because medical help arrives too late or when equipment isn't available. I performed surgery in conditions that would terrify most surgeons. And you've been hiding that experience for 3 months? I wasn't hiding it. I just wasn't advertising it. Dr. Harrison reviewed Emily's commendations again. The citations were remarkable. Multiple instances of exceptional medical care provided under conditions that would have paralyzed most healthcare professionals. Emily, why nursing? With your experience, you could have applied to medical school, become a surgeon yourself. Emily's answer revealed the depth of her character. Because nurses spend more time with patients. Surgeons save lives in operating rooms, but nurses take care of people while they heal. After what I saw in Afghanistan, taking care of people seemed more important than cutting into them. The distinction was meaningful to Emily in ways that Dr. Harrison was only beginning to understand. The 6 soldiers you saved, do you stay in touch with any of them? 3 of them, Emily replied. They send me pictures of their kids sometimes. This simple statement revealed more about Emily's motivation than any military citation could convey. She'd chosen nursing not because she couldn't do more, but because she wanted to do something different. Something that felt more like healing than fighting. Emily, I want to offer you an opportunity. We're starting a trauma surgery training program for nurses. Advanced procedures, emergency interventions. Your experience would be invaluable. Emily considered the offer. Would it mean more attention, more questions about my background? It would mean recognition for capabilities you've already demonstrated, and it would mean better outcomes for patients who arrive here in critical condition. Emily thought about the construction worker from tonight's surgery. He would go home to his family because she'd been able to intervene when conventional protocols weren't sufficient. Can I think about it? Of course. But Emily, I want you to know, what you did tonight reminded everyone in that OR why we became medical professionals in the first place. To save lives when it matters most. As Emily left Dr. Harrison's office, she realized that her carefully maintained anonymity had ended. But perhaps that wasn't entirely a bad thing. Maybe it was time to use her experience to help others instead of hiding from it. From that day forward, the doctors changed their attitudes. No one dismissed Emily's suggestions anymore. Many even consulted her opinion before surgeries. But Emily didn't change her way of living, still quietly cleaning up, preparing instruments, greeting patients with small smiles. A young doctor approached her, apologizing. We were wrong to look down on you. Emily just smiled. Don't apologize to me. Respect every nurse, because one day they might save your life. The chief surgeon, who had stood frozen that day, later called Emily the silent medic, a symbol of quiet strength. Word of Emily's background spread throughout Metropolitan General within a week. The story had been impossible to contain. Too many people had witnessed the emergency surgery, and the outcome had been too dramatic to ignore. But the attention came with unexpected consequences. Dr. Matthews, who'd previously dismissed Emily as lacking confidence, approached her during a morning shift change. Carter, I owe you an apology. I misjudged you completely. Emily was checking inventory on the crash cart, a routine task she performed at the start of every shift. Dr. Matthews, you evaluated me based on the information you had available. That's not your fault. But I should have recognized competence when I saw it. Emily stopped her work and looked at him directly. Doctor, competence doesn't always look the same. Some people are quiet not because they don't know what they're doing, but because they're focused on doing it right. This conversation was repeated dozens of times over the following days as medical staff throughout the hospital reassessed their assumptions about the quiet nurse who'd worked among them unnoticed. Nurse manager Patricia Webb called Emily into her office to discuss the situation. Emily, doctor, Harrison has recommended you for our advanced trauma nursing program. It would mean additional training, higher salary, more responsibility. What would it mean for my day-to-day work? You'd be assigned to our highest acuity cases, emergency surgeries, critical patients, situations where your experience would make the biggest difference. Emily considered this carefully. The program would provide official recognition for skills she developed through military service, but it would also mean increased visibility and attention. Would I still work with regular patients, not just trauma cases? Of course. Why? Because everyone deserves good care, not just the dramatic cases. Webb smiled. That's exactly the attitude we want in our advanced practitioners. Emily's decision to accept the position surprised no one who'd worked closely with her. She'd never sought attention, but she'd never avoided responsibility either. The construction worker whose life she'd saved, James Rodriguez, returned to the hospital 2 weeks later for a follow-up appointment. When he learned about Emily's role in his survival, he insisted on meeting her personally. "You saved my life," he said simply. "My kids still have their dad because of you." Emily's response was characteristic. "Mr. Rodriguez, the entire surgical team saved your life. I just did my part." "The doctors told me what really happened. You did more than your part," Emily smiled. "That's what we do here. Whatever it takes to help people get better." The interaction reminded Emily why she'd chosen nursing over other career paths available to her. Direct patient contact, personal connections, the opportunity to impact individual lives. These aspects of healthcare meant more to her than professional recognition or career advancement. 3 months after the emergency surgery, Emily had settled into her new role as a senior trauma nurse. She worked primarily night shifts, handling the most complex cases that arrived during off-peak hours. But she also volunteered for community health programs, providing basic medical care to underserved populations in the city. Her military experience had taught her that healthcare was most meaningful when it reached people who needed it most. Dr. Harrison observed Emily's development with professional satisfaction. "She's exactly what we needed," he told Webb during a staff meeting. "Someone with exceptional skills who uses them to elevate everyone around her." If you believe that silence can hide true strength, type "respect" in the comments. Emily Carter had found a way to serve that honored both her military experience and her desire for peaceful civilian life. She remained quiet, competent, and dedicated to patient care. But now her colleagues understood that her quietness reflected focus rather than timidity. The silent medic had taught an entire hospital about the importance of looking beyond surface appearances to recognize the capabilities that exist in unexpected places. Emily Carter's story shows, never underestimate anyone just because of their title or appearance. Dismissed as just a nurse, but in moments of chaos, she saved both the surgical team and kept the patient alive. Out there are countless Emilys, veterans, nurses, ordinary employees, carrying experience and courage within them but choosing silence, not showing off. The lesson: respect everyone. You don't know what they've been through and what strength is hidden in that silence. Emily's story teaches us something profound about assumptions, competence, and the invisible strength that surrounds us in everyday workplaces. Every day, we work alongside people whose backgrounds and capabilities remain hidden beneath professional roles and quiet demeanors. The administrative assistant who efficiently handles complex logistics might be a former military officer who once coordinated operations involving thousands of personnel. The security guard who notices every detail might be a retired police detective with decades of investigative experience. Emily's experience represents countless veterans who've transitioned from extraordinary service to ordinary civilian jobs. They stock shelves, drive trucks, work in offices, and provide health care, not because they lack ambition, but because they've found meaning in contributing without seeking recognition. These individuals don't advertise their backgrounds because they've moved beyond the need to prove themselves to others. They've found peace in anonymity and purpose in work that serves others rather than glorifying themselves. But their training, their values, their crisis management skills don't disappear when they change uniforms for civilian clothes. Emily's 3 minutes in that operating room revealed something important. Expertise doesn't always announce itself. Competence doesn't always seek attention. Leadership doesn't always come from those with the highest titles or the loudest voices. The young doctors who dismissed Emily made a common mistake. They equated professional hierarchy with capability, assumed that official credentials reflected actual competence, and confused quiet confidence with lack of knowledge. But Emily's response also demonstrated something equally important: restraint and wisdom. She could have challenged the resident physician's decisions from day one, could have demanded recognition for her superior experience, could have insisted on assignments that matched her capabilities. Instead, she chose to serve quietly, to contribute without demanding credit, and to intervene only when lives were genuinely at stake. This distinction between having the power to dominate and choosing instead to support defines true leadership. Emily's story resonates because most of us have felt underestimated at some point. We've been dismissed, overlooked, or treated as less capable than we actually are. But Emily's example reminds us that other people's opinions don't define our worth or our capabilities. The respect that matters most comes from our own integrity and competence, not from external recognition. The most powerful aspect of Emily's story isn't that she saved a patient's life. It's that she'd been quietly contributing to patient care for months while her colleagues remained unaware of her true capabilities. She maintained professionalism, supported her teammates, and caused no drama. She was exactly the kind of colleague every workplace needs. The next time you encounter someone who seems quiet, unremarkable, or content with a role that appears beneath their potential, remember Emily Carter. Consider the possibility that you're looking at someone whose experience and capabilities exceed anything you can imagine, who's chosen service over recognition, who's found meaning in contribution rather than credit. Respect the silent professionals around you. They've earned it, even if you don't know how. If you believe in stories that touch the heart like this one, leave a comment. And don't forget to subscribe to SN Touching Stories. We tell the stories that shouldn't be forgotten. Real people are creating and telling stories on not mass-produced AI.